All right, so getting into our case review for peds. Let's see. Okay, so peds GI, we have 4 cases to do today for peds GI. So we'll get started with this first one. A 10-hour-old boy is admitted to the neonatal intensive care unit because of abdominal distension. Okay, so what do we think? 10 hours old with a distended abdomen. What sort of things pop to your mind in terms of differential diagnosis? Okay. Absolutely, yeah. That is a big part of neck, is having that abdominal distension. So intussusception, necrotizing enterocolitis, that's pretty good. And this baby's in the NICU, so that also makes us think about, these sort of things like neck that affect babies in the NICU, preemies. The infant was born full term, weighing 6.6 pounds to G1P1 mother via spontaneous vaginal delivery. No fetal distress. The pregnancy was complicated by polyhydramnios. The physical exam after birth revealed upper abdominal fullness. The infant was doing well without any respiratory distress. Okay, so the differential diagnosis when you have a newborn with abdominal distension and vomiting. So you already mentioned a couple of them. Intussusception, necrotizing enterocolitis, and then what do we think this boy might have? Exactly. Yep, you're right. Without worrying about what the actual name of the diagnosis is, what do you think the pathogenesis is? Why do we have some GI problem associated with polyhydramnios? What's the connection there? Exactly. Exactly. That's excellent. Yeah, sure. So Hirschprung's, that can definitely qualify. And then the last one is, like you said, we're not having the fluid going through. It's not passing through the GI tract, and that's what's leading to the polyhydramnios. So anything that causes a stricture or an atresia in the GI tract would present with this. And so for this particular patient, we would think about duodenal atresia. Here we have a baby that the duodenum did not completely open during the 8 to 10 week period, and so because of that, since that period, amniotic fluid has not been passing through the GI tract and resulting in this polyhydramnios state. And now when the baby's born, it's got this distended abdomen. Okay, great. So next best step. What would you want to do to confirm that this is duodenal atresia? Excellent, yes. And what do we look for there? Double bubble, very good. So here is our double bubble, just a quick picture to orient us. You can see that, where's my mouse? I can't see my mouse. But essentially, the side that has the 2 is the stomach side. And then between the 1 and the 2 is the pylorus. And that's sort of what gives you the double bubble, is that you still have a pylorus that provides some narrowing there. And then the 1 is the part of the duodenum that's not atretic. Okay? And so that's how you get your double bubble. You have these 2 areas full of air that are separated by a pylorus. And so our most likely diagnosis, we already said that that's going to be duodenal atresia. Okay, great. So duodenal atresia is the incomplete or partial recanalization of the duodenum in weeks 8 through 10. And so what we see here in duodenal atresia, is that the duodenum itself, here's the duodenum. During embryonic development, the duodenum is not completely patent. It actually is pretty closed off. However, part of development in that embryonic period is that this extra material, all this extra lining of the wall of the duodenum gets reabsorbed to either side. Okay, and we call that recanalization. And depending on how much or how little recanalization there is will determine how severe your duodenal atresia is. And so if it's partial, the atresia may not be that bad. If it's totally unrecanalized, then it would be severe, like in the patient that we just saw. An important thing about duodenal atresia is we have these strong associations with other malformations. GI, cardiac, renal, vertebral. Typically, if you have a patient with duodenal atresia, you need to go looking for other problems, okay? If you have duodenal atresia, you may have a atrial septal defect or ventricular septal defect. You may have a renal agenesis or, vertebral abnormalities like, spina bifida. And so, keep in mind that when you have that duodenal atresia, there's that high association with other malformations. Okay. And of course, there is this pretty strong association with Down syndrome. Okay. And so 25% of newborns with atresia also have Down syndrome. Okay. So that you can look for that trisomy 21 in your genetic analysis and see if that might be there as well. Okay. So symptoms, these patients typically present with gastric distension and vomiting. It may be bilious vomiting, it may not be bilious vomiting. That's all going to depend on how far along the duodenum this atresia is. Okay, and so we have our ampulla here. This is our first part of the duodenum, second part, third part, fourth part. And depending on where in this duodenum that we have the atresia will determine whether or not the vomiting is going to be bilious vomiting. Okay, so don't just assume just because it's non-bilious vomiting, that means it's duodenal atresia. You can have bilious vomiting and duodenal atresia. That's allowed. If you had the problem here, a little bit further along the duodenum, or here in the fourth part, that would definitely give you a bilious type picture. Vomiting typically begins within a few hours of the first feeding. So we're really looking for vomiting in that first 24 hours. And then that history of polyhydramnios is really going to be a helpful key to getting your diagnosis. You know the reason there. This can be diagnosed postnatally using ultrasound and abdominal X-ray, as we did for our baby. However, one thing to keep in mind, especially for step 2, is that these atresia can often be detected during that prenatal ultrasound exam. As part of your ultrasound exam, you're going to be examining the abdomen, looking at the shape of the abdomen, and looking for any abnormalities and looking for the kidneys, things like that. And so you should be able to detect this atresia prenatally. I'm sorry? Exactly. Yeah, well said. So that polyhydramnios, you would see that in the prenatal exam, and now you're going to think, okay, well, why is there polyhydramnios? And then start looking for causes, and this would definitely be something you can look for. One thing to keep in mind is that there's proximal lesions and there's distal lesions, okay? So if the lesion is proximal lesions are going to present with much more severe polyhydramnios. I want you to think about the fact that as amniotic fluid is moving through the duodenum, it's being reabsorbed, okay? And so if your atresia is all the way down here at the distal duodenum, maybe you've had time to absorb most of your amniotic fluid. And so the polyhydramnios is not as prominent. It's maybe a mild polyhydramnios, okay? And so in those patients, we may look at that and say, it's a little bit high, the amniotic fluid level, but we're not concerned about it. And maybe we don't do more workup and look for the duodenal atresia. Versus if we had an atresia proximally in the duodenum, Now, amniotic fluid really has no chance to be absorbed by this baby's body, and it tends to be a more severe picture for polyhydramnios, and that's something that we would be more likely to detect prenatally. Okay? So distal lesions diagnosed after birth, proximal lesions diagnosed prenatally. Our ultrasound findings for our prenatal diagnosis, obviously, like you said, we have polyhydramnios. Seeing a dilated loop of bowel is very helpful. You can actually see your double bubble sign on ultrasound, and we'll look at that in the next slide. So our treatment here, we want to surgically optimize this patient, followed by surgical correction of the abnormality. Okay, so surgical optimization involves NPO, NG tube, or OG tube, depending on what the infant can tolerate. We need to correct any electrolyte abnormalities before surgery, start broad spectrum antibiotics, and then when we do the surgery, essentially we just sort of want to remove the atretic portion distal from the atresia in the duodenum. There should be a perfectly patent jejunum, right? The jejunum is not involved here. It's really just a problem at the duodenum. So if we can take out that area that's atretic in the duodenum, we should be able to have normal bowel function. So here is our double bubble sign of duodenal atresia on ultrasound, and you can see it's a very, very obvious double bubble here. So we have some stomach, we have some duodenum, here's our pylorus, and it's just really giving you that nice prominent picture. Okay. And so this was information for me because I thought you could really only see it on x-ray after the infant has been born, but that's not the case. You actually can see it on ultrasound prenatally. Okay, great. Any questions on duodenal atresia? I'm trying to think. I haven't seen a question. I think the important thing is that you just are cognizant of the fact that it is diagnosable via ultrasound. Like that would be the first test to do if they were to ask. But just off the top of my head, I can't think of a question that I saw using the ultrasound, you know. Yeah, I haven't seen it, but it's definitely part of the management and something that I mean, if you're looking for first aid, probably you would see it as well. The other thing that you can notice from this picture is look at all of this space, right? That's a lot of polyhydramnios in this particular patient, which you know it works with, or it goes along with our diagnosis. All right, great. So just high yield points, incomplete recanalization. We have that strong association with other malformations. You know, you need to look for that in your question. Symptoms presents with gastric distension, vomiting, and we can diagnose it with the ultrasound and surgical optimization. Great. Okay, so here's our next case. We have a 8-month-old boy with no significant past medical history presenting to the pediatrician with irritability, 1 episode of stool mixed with blood and mucus. Okay, so what is something that can give us nasty, bloody stool at this age? Well, a little bit old, right? 8 months. That. Yeah, absolutely. Yeah, I could see Hirschprung's doing that. You know, a baby presenting with bloody, nasty stool. You can also think about maybe some kind of bacterial, you know, a severe bacterial infection like a Salmonella typhi or something like that. You know, whenever you have that bloody stool, it's not a good thing. So his mother notes that he began crying inconsolably for 30 minutes after waking up early from his morning nap, then began acting like himself again. An hour later, he began crying again, was noted to be pulling his knees towards his abdomen. He continued to have... Very good. Yes. Intussusception. Yep. Nailed it. Continue to have episodes of irritability, crying that lasted 20 minutes and occurred at 30 to 45-minute intervals. On examination, no fever, vital signs within normal limits, normal rectal tone, but he does have that FOBT positive stool. So, like you said, most likely diagnosis is going to be intussusception. The important thing, which I think probably helped really clinch the diagnosis, is just this colicky nature of this particular pathology. So it's really severe, it goes away, then it's severe again, and it goes away, it's severe again. So having that colicky nature plus the bloody stool, those two together really is really high yield for this diagnosis. What do we expect to see on physical exam? Yep. Good. Yes. Good. So we should feel it, and the way that they usually describe it, although not always, is like a sausage-like mass. And so you'll be able to feel this, I guess, a sausage in this patient's abdomen, and it's typically going to be in the right upper quadrant. Okay, that's where the intussusception tends to go. So best diagnostic test. X-ray, okay. What else? Give me your next guess. Good. Okay, I like that you said barium, because the barium enema is going to be therapeutic and diagnostic, so that's a nice one to do. But the first thing that you really do with these kids is just do an ultrasound. Ultrasound abdomen, and then the classic sign that we look for is going to be the bullseye sign of the telescoping part of the bowel that's entering the other part of the bowel. Okay, so we look for a bullseye sign. Okay, so intussusception, this is going to be our most common cause of bowel obstruction in the first 2 years of life. Holy cow. That sounds high yield, okay? So if you have someone present under age 2 with a bowel obstruction, first thing you should think of is intussusception, okay? And now I think that when we talked about SBO, we said that hernias were the most common cause of bowel obstruction in the first 2 years of life. However, there's a small difference here. So in intussusception, the part of bowel that we have in telescoping into the other part of the bowel is typically the terminal ileum telescoping into the cecum and the proximal large bowel. Okay, and so when this little bit of ileum goes up into the large bowel, we end up with an obstruction. Okay, so everything is okay here because this is going to be a large bowel obstruction. Small bowel obstruction is going to be the most common cause, is going to be hernias. Okay, so it's a little bit of a semantic difference here. But when you talk about large bowel obstruction, the most common cause is going to be intussusception. Small bowel obstruction is going to be hernias. Okay, kind of bringing it together. Great. So it involves a portion of the bowel, often containing a lead point, telescoping into the adjacent bowel. So depending on the etiology of your intussusception, that can change what your lead point is. And these exams, Step 2 CK and UWorld, want you to have a nice differential diagnosis of what these lead points can be. Okay, if they give you a patient with cystic fibrosis, you need to know what the lead point is. And so the safest way that I think about this condition is that the lead point is usually an enlarged lymph node or a piece of dead bowel. Okay, and so let's look at these different cases. So in cystic fibrosis, we have thick inspissated stool acting as a lead point. Essentially, it's kind of getting stuck against the wall and allowing, whenever the bowel moves, it kind of moves along with it, and it ends up pulling bits of the bowel forward into the colon. Okay, and so great. So that's cystic fibrosis. Henoch-Schönlein purpura. here we have a small bowel hematoma acting as the lead point. Okay, and so in Schondlin purpura, this is a vasculitis, inflammation of some of our small vessels. When you get that inflammation in the wall of your bowel, that can end up causing leakage into that wall, causing a hematoma. That hematoma has weight. And so now we have this weighted object inside of the wall of our bowel that is going to move along with the bowel and ultimately act as a lead point. Meckel's diverticulum, parasites like Ascaris lumbricoides, very uncommon, right? Adenovirus and preceding gastroenteritis. In most cases of intussusception, these are going to be our usual suspects. When you have adenovirus or even just a mild gastroenteritis, that's going to cause a swelling of the lymph nodes here in the terminal ileum, the lymph nodes here in our cecum and in the ascending colon. And so now we have a solid weighted object that can kind of pull the bowel along with it. Okay, and so with our adenovirus gastroenteritis, this is why we get it, because of that swollen lymph node. Small bowel lymphoma, this is going to be typical if you have someone that's older than age 6 and develops intussusception. You have to start thinking about lymphoma. Okay, it's something that probably wouldn't be the first thing that pops into your mind with intussusception, but is definitely a significant cause, especially in older kids. All right, so in terms of symptoms, we talked about, there's a sudden onset. It's going to be severe, crampy, progressive, typically inconsolable crying, drawing the legs to the chest. Look for that current jelly stool, which is that blood and mucus mixed together in the stool. Okay, it gives it that thickness. Sausage-shaped mass may be felt on the right side of the abdomen. Typically, it's going to be right upper quadrant of the abdomen, okay, because we have a little bit of this terminal ileum, which is on the right side, that's telescoping upwards into the ascending colon. And so typically, as that happens, you may feel even just an absence of anything in the right lower quadrant. As you're palpating, you don't really appreciate any bowel under there. And then when you move to the right upper quadrant is where you feel a mass there, and that would be your actual intussusception. So abdominal x-ray, you may see the obstruction, giving you those dilated loops of bowel, lack of air in the right lower quadrant. Crescent sign is just a bit of the wall of the bowel that's kind of hyper intense on x-ray and gives you this crescent sign, basically a thickness of the wall that looks a lot brighter when you do it in x-ray. And so that's your crescent sign. Abdominal ultrasound. This is highly sensitive, highly specific. This is our best test for intussusception. We're going to look for that bullseye lesion, which is just a little bit of bowel inside of another bit of bowel. Barium enema is really great here because it can confirm the presence of that telescoping intraluminal intestinal mass, but the best part about it, it's therapeutic. And so if we do an air barium enema, we're actually going to push that bit of bowel out of the bowel that it's telescoped into, and really just kind of cure our patient. It's really a beautiful thing because our patient's just going to instantly feel better. And the other thing about it is recurrence is uncommon. So a patient has this one time and typically is not going to have it again. Okay. So in kids, it's pretty easy to identify. There's not a lot of other disorders that cause this, crampy, colicky abdominal pain with that, bloody red stool. Okay, now, the difficulty is, I think, when you have intussusception in adults, because intussusception and volvulus end up looking very similar in adults, okay? And so, important things about volvulus is that it commonly happens on the left side of the body. So we're talking about the sigmoid colon is usually the most common place that you'll have bowel wrapping around itself in volvulus. Okay, and so if our patient has symptoms on the left side, you want to think more towards volvulus. Symptoms on the right side, you want to think more towards intussusception. Okay. In general, intussusception is not common in adults. It's very, very rare, but it does happen. When I was doing my surgery rotation, we had a patient with intussusception who was 40, 50 years old, so it's possible. All right. Okay, so what are we looking at here? Yeah, awesome. Yeah, like a dartboard, essentially. They should call it dartboard sign because it looks like a dartboard, but they call it bullseye sign for whatever reason. And you can see like there's multiple layers of wall here that have actually kind of come in, and so you really can see why that leads to an obstruction. Okay, great. Okay, so high yield points, portion of bowel, think lead point of lymph node or dead bowel, you know, sudden, intermittent, crampy, progressive abdominal pain, vomiting, passage of current jelly stool, you get that sausage-shaped mass. Abdominal ultrasound is sensitive and specific to identify, and then the barium enema is going to be therapeutic, okay? And you'll hear this described as air barium enema. We're just basically filling the colon with just a bunch of volume so that we can kind of pop this thing open, okay? So memorize it as air dash barium enema. I forgot to add that in, and that was my mistake, okay? Okay, great. So case 12, we have a 6-day-old girl born at 35 weeks gestation, evaluated because of a 24-hour history of abdominal distension, decreased feeding, and vomiting. Okay, what do you like for this one? Or just a general, I'm not asking you to diagnose this patient, but just like, so just give me a couple things that pop to your mind. This is like the exercise I'd like you to do, even when you're doing questions and I'm not there yelling at you. When you read that first line of a question, then give you the patient, just like take 1 second, 2 seconds, and just like think, okay, this could be boom, boom, boom. It's going to orient you to the question. It's going to keep you focused, and as you move through the question, you're going to be eliminating those differential out of your mind. So then now when you get to the question stem, you can actually have a much more focused idea of what this disorder is, rather than just kind of going through it willy-nilly and just trying to guess along the way. We're going to make a quick differential of things this could possibly be and then move through, okay? Great. Absolutely. Yep. Abdominal distension, decreased feeding and vomiting. Meconium ileus definitely qualifies in there. So she was delivered by induced vaginal delivery, great, to a mother with preeclampsia. Stabilized in the NICU, doing well, no signs of respiratory distress. Over the past day, she gradually became more irritable, has been vomiting her formula. The last stool she passed was guaiac positive. There's a little blood there. The nurse describes one episode where she appeared to stop breathing. On examination, she appears lethargic, is lying still. Temperature elevated, heart rate 145, blood pressure 91/60, respiratory rate 20. The birth rate was 2 pounds 8 ounces, and the current weight is just 2 ounces less. Abdomen is distended, tender to palpation with decreased bowel sounds. Okay, so, I'm sorry? Yeah, they do. Okay, no problem. So, so like you said, the important thing that you're being given here is number one, it's a preemie, okay, and number two, this baby is 6 days old. Okay, so why is that important to me? Because what that tells me is this is not a problem that the baby was necessarily born with. 6 days old means this baby has had a chance to pass her first stool, right? That happens within the first 48 hours. She's had the chance to feed. Obviously, she's been feeding for the past 6 days. She's had a chance to, you know, do a lot of these things. She's been in the world for 6 days. And so something's happened in those 6 days to cause the current problem, okay? If this patient was presenting at the first 8 hours, are differential changes, because this is probably something the baby's born with. Versus now we have a preemie who's been, eating and probably stooling for the past 6 days, and now is starting to get sick. Okay, and so that is going to kind of change the way that we think about this. So when you have preemies, one of the big problems is in their GI tract, the vasculature is not that mature. The vasculature it's still really developing, and it's going to take some time for all of the arteries and all the veins, all those little capillaries to fully develop. It's not done yet. Okay, and so when you have that immature bowel, and then you introduce something like formula, what can happen is that the GI tract, in trying to work through that formula, trying to break it down, trying to absorb all of it, requires a lot of blood flow, and it doesn't get that blood flow. So now you have parts of the bowel that become ischemic. Okay, so that maybe happened at day 3 or 4. Now that we have ischemic bowel, we have bacteria that love to invade and cause an infection in ischemic bowel. That's what they love to do. So now we have a situation where we have bacteria growing in the wall of the bowel and causing a very severe condition. Okay, so the things that really give us this diagnosis is the fact that she's 6 days old, the fact that she's very, very tiny, 2 pounds 8 ounces, the fact that she's a preemie, all those things together. So even though she's 35 weeks, you can be born 35 weeks and still be a 5, 6, 7 pounds. This mother also had preeclampsia. Okay, and so that's the other bit of this patient presentation that we want to keep in mind. So with all that together, does any other diagnosis pop up in your mind? Yeah, excellent. So this is going to be our necrotizing enterocolitis, which is a ischemic bowel followed by a bacterial infection of the wall of the bowel. Okay. That's true. I didn't point that out. That's an excellent point. And so having that fever tells you that there could probably be some infection going on. Okay, very good. And the other thing also to keep in mind about, when we talk about infants and all of our vital signs, is that it's very hard to judge what's going on with a baby from their vital signs. I mean, obviously, if it's 100.1, that is a fever. You can say that. But you can also have babies that become septic that have a temperature of like 96, right? So, yeah, the temperature stability is not really there. Okay, great. So imaging findings are typical in this condition. We do an abdominal X-ray. This is something kind of specific that I'm asking about. It's basically when you have that bacterial infection in the wall of your bowel, you end up having these small little bubbles, essentially, in that wall of the bowel. And so what is called is pneumatosis intestinalis. It's on the next slide. Don't worry about writing it down. And so that is the imaging finding that they may ask you about on step 2, is these little air bubbles in the wall of the bowel. It's called pneumatosis intestinalis, and that tells you that there's some sort of infection going on there to cause this condition. What is the management of this patient? What would you want to do? Just generally, nothing super specific. Good. That's all I was looking for. Perfect. Yes. NPO, replete fluids, and give antibiotics, right? We want to stabilize this patient. Eventually, we probably are going to have to go to the OR to remove any of the dead bowel and to prevent further infection. But yes, so the initial management, fluids, NPO, and antibiotics. So necrotizing enterocolitis. We have bowel ischemia with superimposed bacterial invasion of that bowel wall, most common in preemies. The signs and symptoms, we look for that temperature instability, lethargy, apnea, vomiting, bloody stool, abdominal distension. Like you said earlier, and I completely 100% agree with you, a lot of these tend to run together, right? You have this baby that has some GI problem, I don't know. It's just like a bunch of stuff that could be going on. So we really want to look at how old that baby is. A baby that's presenting within the first 24 hours has a very different differential diagnosis than a baby that's presenting at 1 week, like the baby in our question stem. Okay. On X-ray, we can look for pneumatosis intestinalis. This is just, like I said, those bubbles in the wall of the bowel. I didn't add a picture in here. I should have added a picture, but if you Google this term, you'll be able to see some nice images of what that looks like. Air in the portal vein, which is basically showing you have a bacterial infection in your GI tract that is causing air to enter the portal vein. Free air under the diaphragm, that is definitely a sign that you need to go to the OR because your baby is now perfed. We now have a perforation in the bowel, and that's allowing air to enter the free space in the peritoneum. Okay. Bowel rest, NPO, NG tube, IV fluids, antibiotics. This is like, did you look at this slide earlier and you read off of it or something? That was just what you said. Perfect. I like it. We will be doing serial abdominal x-rays to evaluate for perforation, keeping an eye out for increasing in the amount of air that we see in the wall of the bowel, increase in the air under the diaphragm. And then if the patient perforates, we have to go to the OR. Okay. The prognosis for this condition, unfortunately, is poor. There's a high rate of mortality due to the sequelae of bowel perforation. We have a bacterial infection now that's very close to our vascular supply, so our patient can become septic. And then we're also concerned for shock. There's just a lot of things that we can be concerned about. But if our infant is able to make it through this period, what are our long-term complications? Things we worry about are strictures. Areas that become narrowed in the GI tract because of this condition, and short gut syndrome, which is essentially where our patients don't have enough time to process everything that that they eat on the daily, and so this short gut syndrome really requires increased vitamins, increased. I'm sorry. Yeah, exactly. Malabsorption. Yeah, well said. Yeah, so we're not able to absorb things before they pass through. Very good. Okay, very good. Okay, so next question here. Here we have a 3-day-old boy brought to the pediatrician by his mother, who is worried that her son is turning progressively yellow. Okay, so just a quick differential. What pops to your mind? Yellow baby. Yep, exactly. And that's where you should be at this point. It's 3 days old, and we'll talk about the first 24 hours versus after the first 3 days, because that's an important distinction point. But otherwise, you just know there's something to do with bilirubin. You can't really say much else at this point. So he was born by spontaneous vaginal delivery at 36 weeks. Great. Good prenatal care, no complications. Discharged from the nursery at 30 hours. And so this is an important point because it's telling us that he was not jaundiced at the first 24 hours. Breastfeeding and stooling well. Okay, so they're telling us that he is breastfeeding. So that's another clue as well. On examination, he is a well-appearing infant with marked jaundice over his face and torso. Most likely diagnosis. Yes. No, so yeah, so physiological jaundice, it's physiological, and so there's not really a more specific diagnosis you can give. The other thing that would be on your differential here is just your breastfeeding jaundice. Breastfeeding jaundice is a type of physiological jaundice, so that definitely encapsulates what your answer would be. So for this particular patient, we would probably say breastfeeding jaundice, just to be as specific as possible, because they did tell us that he is breastfeeding. Okay. What would bilirubin levels show? And so what I'm really asking you here is, would you expect to see high levels of conjugated bilirubin or high levels of unconjugated bilirubin? Very good. Yes. Yes. So typically when we look at our bilirubin levels, what we would see is the way that they would give it is they give total bili, and then they give our conjugated bili, they don't tell you your unconjugated bili. They'll tell you total bili, and it'll be something like, I don't know, 11. Okay, and then your conjugated bili will be 0.5. Okay, and then so just looking at that number, we can tell that our unconjugated bilirubin would be 10.5. And so that elevated unconjugated bilirubin is typical of physiologic and breastfeeding jaundice. Sure. No, it should not. Yeah. Mm-hmm. 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 Yes. Sure, that's a great question. And so we're going to talk about it on the next slide. But essentially, you said 15. I feel like you know already. But 15, yes, you're absolutely right. That is the cutoff. So 15 is the cutoff, yeah. So under 15, anything under 15, we can say physiologic jaundice. And we really don't need to do any intervention. Over 15 is where we start getting concerned about pathologic jaundice and needing to do, plasma exchange or, UV light, doing all of these interventions to drop that bilirubin. Okay. So 15 is well said. That is going to be your cutoff. Okay. So what are the two types of jaundice associated with breastfeeding? So one is this breastfeeding jaundice we've discussed. There's one other one. No problem. So breastfeeding jaundice, this is a jaundice that is associated with the lipids that are in the breast milk, essentially. So whenever you see breastfeeding jaundice, just think of a baby that is breastfeeding and is getting these lipids from the breastfeeding, okay? The other type of jaundice associated with breastfeeding is called breast milk jaundice. In breast milk jaundice, it's because the baby's not getting enough breast milk. Okay, and so in that case, the baby is undernourished, and that's what's leading to the jaundice. Okay, so breastfeeding and breast milk, those two they used to kill me. Still probably kill me a little bit. You really just got to memorize which is which, because they will give you both of those as answer choices and expect you to be able to differentiate between them. Yeah, exactly. Essentially, so I just want to say this again because I think I actually said it backwards. So there's breast milk jaundice and there's breastfeeding jaundice. In breast milk jaundice, it's the lipids in the milk that are causing the problem. So the baby's drinking enough milk, but there's just these lipids that are causing the problem. Versus breastfeeding, the baby's not feeding enough. Okay, so in breastfeeding jaundice, it's the feeding that's the problem. The baby's not getting enough. And breast milk jaundice, it's stuff in the milk that's causing the problem. I'm telling you, like, these two, they sound exactly the same. I swear, like, some of these pediatricians are evil people because they name these things very similarly. And I apologize for that. So, again, just to be totally clear, breast milk jaundice, the problem is what's in the milk. We have these lipids that cause bilirubin levels to rise. Okay, still physiologic though. In breastfeeding jaundice, the babies are not feeding enough, and they're essentially not getting enough nutrition, causing elevation of bilirubin levels. Okay. Yes. Yeah. So for breast milk jaundice, it goes away. It's really just the liver needs to catch up in its ability, that glucuronidase transferase, all those enzymes need to develop a little bit more. So the jaundice will go away. There's nothing really you need to do. You don't want to tell your mothers to stop breastfeeding. They can continue breastfeeding. If the bilirubin levels are really getting high, I'm talking like 12, 13, 14, getting close to that level, okay, now you can maybe switch to formula and put the baby in some sunlight. Otherwise, there's not really much you need to do. Eventually, it will catch up if it's true physiologic jaundice. Yes. Mm-hmm. Mm-hmm. Mm. Right. So yeah. So breast milk jaundice would happen to all breastfed babies. Breastfeeding jaundice could potentially happen to formula-fed babies if they're not getting enough. That one is all about nutrition. Breastfeeding jaundice is all about nutrition. And so if you have a baby, whether the baby is breastfeeding or drinking formula, if the baby's not getting enough nutrition, it can lead to breastfeeding jaundice. Okay, the baby's not feeding enough. Okay, great. So prenatally, bilirubin is cleared through the placenta. Now the baby's born and it doesn't have that placenta to rely on. So we have an increase of bilirubin coupled with a decreased hepatic uptake and conjugation. The enzyme they always want you to know is that UDP glucuronol transferase that conjugates bilirubin and allows it to be cleared. So this is going to lead to a universal hyperbilirubinemia within the first week of life, meaning most babies are going to have elevated bilirubin levels in the first week of life. They're not necessarily going to be bright yellow, glowing in the dark, but they should, if we check their blood, have a little bit of an elevated bilirubin level. Okay, and so now we're going to start talking about time cutoffs. Physiologic jaundice is generally seen after the first 72 hours. Okay, so your baby should not be jaundiced within the first day of life, usually not within the second day of life. If the baby starts to get jaundice in the third day of life, we can kind of classify that as probably being physiologic. There's other causes that can be later than 72 hours, but physiologic jaundice would never be in the first 24 hours. Okay. Typically, it's going to peak after 3 days, resolve at over a 2-week period. Really, even a 1-week period is more typical, but we can extend that out to 2 weeks for some cases. So really, even 1 week is the cutoff that you're going to see a lot of texts using. Okay, that 1 week cutoff is how long it takes to resolve. The bilirubin will peak under the level of 15, and we look for that large component of unconjugated bilirubin. When we do our bilirubin analysis, we should see a relatively normal amount of conjugated bilirubin. Direct bilirubin should be relatively normal. And then our total bilirubin will be elevated, okay? And that gives us our large component of unconjugated bilirubin, okay? The exact amount that we really look for is under 10% of conjugated bilirubin. Conjugated bilirubin, okay? And so if we had, say, a level of 12 for our total bilirubin, our direct bilirubin should be under 1.2. Okay, great. Pathologic jaundice is seen in the first 24 hours, persists beyond 1 week. It can be unconjugated or conjugated, but usually we look for a component of conjugated bilirubin greater than 10% conjugated bilirubin. Okay, conjugated bilirubin. Bilirubin is going to It's going to peak greater than 15, and this is why it's considered pathologic. Because once we have bilirubin greater than 15, we are going to start having a risk of developing kernicterus. And so, yeah, in kernicterus, we have deposition of this bilirubin in the basal ganglia, in the pons, in all of these important areas of the brain, which can lead to, a lot of very severe problems. So lethargy, poor feeding, high-pitched cry, seizures. Jaundice may follow a cephalopedal progression as bilirubin concentrations increase. So as we're looking at our baby, we can even see a gradient where at the tip of their head looks a bit more yellow than the tip of their toes. And so that's sort of one thing that we can look for as well. Kernicterus typically requires a bilirubin level greater than 20. Okay, and so that's why we have that 15 cutoff, because once we're getting close to 20, now we're really putting our patient at risk of developing some serious health issues. Okay, and so this is a diagram chart from our first aid for CK. And so on the left, we have all of the things we look for physiologic. On the right, we have pathologic. So physiologic is not going to be present until 72 hours after birth. Bilirubin increases by 5 milligrams per deciliter per day. I found this particular aspect of jaundice difficult to remember, and they usually gave me other stuff anyway. I never solved a problem on step 2 because of this particular fact. Okay, I personally don't find it helpful. Same thing for pathologic. I don't really find this helpful, but it's there if that's something that helps you. Basically, it's saying that the bilirubin is rising slowly in physiologic and rising more quickly in pathologic, but again, it was not helpful for me. Bilirubin is going to peak at under 15. Direct bilirubin should be less than 10% of the total. It's going to resolve by 1 week. Okay, so pathologic, present in the first 24 hours of life. This is going to be one of our most high yield things in terms of building that differential diagnosis. How old is the baby? When did we first start seeing the jaundice? That's going to be a huge clue into the etiology. Okay, bilirubin is going to be peaking at greater than 15. Direct bilirubin makes up a greater component of the total amount of bilirubin. And persisting beyond 1 week is another thing that can really clue us into our differential. Okay, so when you have a baby that's maybe 2 weeks old, 2.5 weeks old, and they're still jaundiced, okay, this is probably pathologic. This is not going to be our breast milk, not going to be our breastfeeding. This is going to be pathologic. Okay, so our differential diagnosis for non-physiologic jaundice, aka pathologic jaundice. So anything that can cause jaundice in an adult can absolutely cause jaundice in a neonate. Okay, so think about increased bilirubin production. So if we have some sort of hemolysis, if we had a condition where we had ABO incompatibility between the mother and the baby, there may be some of those antibodies still left over in the baby's blood supply that are causing hemolysis. Okay. Sepsis for the baby obviously is going to look a little bit different. Hematoma or hemorrhage. And so cephalic hematoma is when we have a hematoma that is within the scalp. Okay. This is just sort of one of those things that can happen during childbirth. And, typically what happens is slowly over a period of 1 to 2 weeks, the blood that's in that hematoma in the scalp gets reabsorbed. For cephalic hematoma, we don't do any kind of surgical intervention. It's just a little bit, it's a hematoma, right? It's just a little bit of blood trapped in an area where you're not supposed to have blood. So that blood will be resorbed. However, as we're resorbing that blood, that's going to be a whole bunch of extra bilirubin and, hemoglobin we have to break down into bilirubin. And so that can result in a little bit of non-physiologic jaundice. However, typically that is not going to lead to a kernicterus state. Cephalic hematoma is not really big enough to dump that much hemoglobin onto the body. Increased enterohepatic circulation, so some sort of bowel obstruction and ileus. Decreased clearance of bilirubin, so in our very premature infants, this is why we put all those preemies under those UV lights, because while a normal term baby still has that enzyme deficiency, imagine those preterm babies. They'll probably have an even more severe enzyme deficiency. Okay. Sure. Maybe. Sure. Yeah. Definitely. Seeing any kind of, signs of bruising, in that young baby is a sign. Now, with abuse, we really, rather than think about cephalic hematoma, we really think about a subdural hematoma. Okay. And so in our subdural hematomas, if this is the bone of our scalp, here's our dura, here's the brain, here's the pia mater that's protecting the brain. So in subdural hematoma, we have these very gentle bridging veins that go from the dura to the actual white matter of our brain, right? Gray matter of our brain. And so these veins are very gentle, especially in babies, especially in the elderly. And so for abuse, when we worry about shaken baby syndrome, we worry about rupture of these veins, leading to blood extravasating over the entire brain itself. Okay. And so if we were to do an x-ray of our newborn, when we're suspecting abuse, what we look for is a crescentic blood along the surface of the brain. Okay, so that's what we typically look for. This blood can accumulate and cause, you know, parts of the brain to shift over. We can have, like, you know, our uncle herniation, all these types of things due to that hematoma. Okay, and so that's our subdural hematoma. Okay, very good question. Good question. And absolutely, with all of this extra blood, we can definitely get a jaundice as our body tries to reabsorb some of this blood from the hematoma. So for G6PD, you know, this can cause jaundice in an adult. Why not in a kid too? Okay, so any sort of stress, exposure to, you know, sulfa type drugs. If we're maybe giving this child some Bactrim, we thought the child was septic, and now they're becoming jaundiced after we give Bactrim. Okay, now we can start to suspect G6PD. Okay. Yeah, absolutely. Yeah, absolutely. Very good. Yeah, any kind of hemolytic anemia. So, you know, when we think about our ABO incompatibility between the mother and the baby, you know, sort of the RH status, if, you know, RH incompatibility typically leads to hydrops fatalis, but if it's not that severe, you can have some hemolytic anemia. But yeah, excellent point. Any type of hemolytic anemia can cause this. Even a spherocytosis could lead to this. Yeah, very good. So inborn errors of metabolism. We have our Crigler-Najjar. We have our Gilbert. There's also that Dubin-Johnson that we talk about, which is our more benign inborn error of bilirubin metabolism. So our worst inborn error metabolism is going to be our Crigler-Najjar. In this condition, we have a complete absence of our UDP, glucuronyltransferase, is completely gone, and so bilirubin levels are just going to go up and up and up and up. And so this Crigler-Najjar is typically going to be deadly. Gilbert, a little bit less severe, can be managed, you know, with our UV lights and other things like that. Galactosemia, we're missing certain enzymes for our galactose breakdown pathway. And then for metabolic, hypothyroidism can also lead to jaundice. Okay, so it's a pretty wide differential diagnosis. This is not something that you need to have, you know, sort of on the tip of your tongue for your exam, but you know, just sort of thinking about things that cause jaundice, keep your differential wide. And as you were doing, as we went through this and sort of, you know, suggesting different things, which I really like. I like when you suggest things. It definitely helps. That is what you need to be doing during your exam, thinking of, okay, well, this causes jaundice, this can't really cause jaundice, and then, you know, kind of evaluating the question options that way. Mm-hmm. 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 Yeah. No. Right. Yeah, so our Dubin-Johnson, in Dubin-Johnson, we are able to conjugate bilirubin, okay? And the problem is just kind of excreting it. And so what ends up happening is we get a black liver because all the bilirubin just kind of sticks around, okay? So Dubin-Johnson is going to be our black liver. And the last one is going to be Rotor. And Rotor is the same as Dubin-Johnson, but just no black liver. Okay. No. Yeah. I think Dubin-Johnson even, like, it was discovered on autopsy. They were doing an autopsy for something else, and then they looked at the liver. They said, holy cow, this guy has a black liver. What happened? And then so that's sort of how they discovered it and learned about the condition. But, I mean, I may have Dubin-Johnson and not know about it. I don't, as far as I know, I don't, but it's possible, right? It's very asymptomatic. And I believe in Dubin-Johnson you can have a little bit of jaundice when you go through stress. But in general, it's asymptomatic, not something that needs treatment. Yeah. Very good. So to answer your question, yes, the most important things we need to consider for in the context of pediatrics, definitely all of these increased bilirubin productions are hemolysis, very important, hematoma, very important. You know, all of our enzyme deficiencies with the decreased clearance and the errors in metabolism are very important for non-physiologic jaundice. So evaluation and management. First thing we'll do is a blood smear, look for hemolysis. You know, in any case we see indirect bilirubin, you know, hemolysis leads to just free bilirubin floating around in the bloodstream. So if we have hemolysis, we're going to see that high unconjugated bilirubin component. And so a blood smear, we can look for hemolysis. Great. Coombs test, we can look for that ABO incompatibility. And we can really differentiate if we see some sort of hemolytic anemia. We don't know whether it's due to ABO incompatibility or some G6PD versus hereditary spherocytosis. We can do a Coombs test. Coombs test positive, okay, that means that, you know, the problem's coming from the mom, versus G6PD or Coombs test negative. We would think, okay, this baby has something that's resulting in a genetic hemolytic anemia. Okay, and so we can think about these. Other tests we can do are LFTs, ALK-Phos, look for problems at the level of the liver. Bile acids, we can do a sweat test to look for cystic fibrosis. We can, you know, identify the diagnosis if we see that direct bilirubin component, rule out some of the problems with digesting amino acids, such as our PKU, right, can have a little bit of jaundice. Alpha-1 antitrypsin deficiency, we have a problem at the level of the liver. So septic workup, if you know it's pointing in that direction. Any jaundice neonate with fever, hypotension, tachypnea, think about sepsis. Maternal fetal ABO, RH incompatibilities is going to be a immune-related hyperbilirubinemia. In terms of treatment, depending on the etiology, for physiologic jaundice, breastfeeding moms can keep breastfeeding. Yes, there's these lipids in the breast milk that are causing a jaundice, but it's going to go away. Unless the bilirubin is really getting quite high, we don't really need to do much about it. Phototherapy is indicated for bilirubin levels greater than 15 regardless of cause. Physiologic, non-physiologic, put them under that UV light. It's pretty harmless. In severe cases, we can do an exchange transfusion where we are basically cleaning out the blood, removing all that bilirubin, and preventing advancement of disease. Okay. All right, great. Any questions on jaundice? No? Okay. All right, good. So that is going to be our lecture for today. When we meet next time, we're going to go over one more case, which is a pretty slam dunk case for you. I don't think you'll have any trouble with it. And after that, we can start our next topic, I think. Do you have a topic that you'd like to go over next, something that you've been struggling with or that you feel like is particularly difficult? Mm-hmm. 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 Sure. Uh-huh. Yeah. Okay, okay. Uh-huh. Yeah. I think that's a great strategy, Daphne. I think that's a great strategy. And, you know, when we do these lectures together and you hear me say it and then you go back and study it later, it really reinforces